folks. Today's speaker, first of all, my name's Peter Greer, and I'm with the Cancer Biology and Genetics group in the Cancer Research Institute. And so it's my pleasure to try and recruit at 3 speakers a year for the oncology grand rounds. And I was lucky enough to get Dr. Tricia Cottrell to agree to give a presentation today. And I think most people here know Tricia. She's one of our own from Queens here. Just briefly, for those of you that don't know her, I'll give you a little bit of her background. So Tricia did her BA degree at Washington University in an interesting combination degree in chemistry and English literature. Have to talk about that sometime. But then she went on to do MD PhD training at Johns Hopkins. And she did pathology residency there at Johns Hopkins afterwards with a concurrent postdoctoral fellowship. We were able to recruit Tricia to Queens in the summer of 2029. So she's an assistant professor in the Department of Pathology and Molecular Medicine. And she provides anatomic pathology clinical service there, but I think most of her time has been dedicated to establishing a very active, independently funded research program here. So she's a senior investigator with the Canadian Cancer Trials Group. And to establish her program, she obtained, I think it's around $2 million for infrastructure and operating grants from various sources, including CFI, ORF, OICR, and a 5-year grant from the CIHR. Congratulations on that. That's a great kickstart to our research program. Her CCTG roles include Deputy Director of the Tumor Tissue and Data Repository, and she co-leads the Neoadjuvant Clinical Trials Platform, which has been identified as a priority for the upcoming 5-year CCTG strategic plan. She's also a member of the Center for Health Innovation and is co-leading a $3 million renovation to expand the digital pathology capabilities. And this will be important for CCTG as well as the Department of Pathology and Molecular Medicine and the Queens research community in general. Tricia has been remarkably active in teaching since arriving at Queens. This includes medical students, graduate students, residents, and a stream of undergraduate students going through her lab too, quite a remarkable number. I think there's over a dozen of these in the last couple of years. Many of these students have benefited from our ongoing international collaborations, which includes investigators at Johns Hopkins. And a lot of this involves using now her local AstroPath platform for multiplex immunofluorescence, tumor immunophenotyping, which a lot of her research revolves around. Her publications include a couple of first author publications, recently, and contributing authorships to some very high impact studies published in Science and Nature. So I'll stop there and let Tricia begin her presentation. Her title of her talk today is Pathological Response Assessment in Non-Small Cell Lung Cancer Neoadjuvant Clinical Trials. So Tricia, take it away.
Thanks, Peter. That was the nicest introduction I've ever had. I hope I can live up to it. So I'm going to focus today really on more of a pathology issue than a biomarker issue, I guess. So I have the multiplexing slide back here, but I'm not going to talk about it. And I'm also happy to have this be more of a discussion if people are interested. So feel free to chime in with questions. I have the chat and the participant list open, so hopefully I'll see them, but if not, feel free to interrupt if you have questions. I think this is a very timely topic. There's a lot happening in this space in the clinical trial setting, and it'll trickle down obviously into clinical practice pretty quickly. So I think this is a good one for us to chat about today. And let's see if I can advance my slide. So I'm going to define features of immune-mediated pathologic response. So we're going to sort of get in the weeds a little bit on some pathology, and then talk about the Checkmate 816 clinical trial, which was the phase 3 BMS trial of nivolumab plus chemotherapy in resectable lung cancer that recently led to a Health Canada approval for this indication. And then finally, I want to just sort of propose something that feels a little radical, but I think that we could actually have a pan-tumor approach to pathologic response assessment, which has significant implications both for the clinical practice of pathologists, but also for data collection and reporting in clinical trials and how that will impact regulatory approvals for new therapies. So with that, I would like to start with my take-home messages. I like to emphasize to folks, and this is a Frankenstein set of a slide deck here from various presentations I and others have been giving recently, but I like to emphasize to people that immune checkpoint blockade is not chemotherapy 2.0. So they're fundamentally different mechanisms of action, and that has implications both for treatment settings and pathologic response assessment. Our ability to standardize our approach to these therapies and clinical trials is really going to define whether or not we're able to accelerate the rate of getting new therapies to patients. And, you know, in general, I think revolutionary neoadjuvant trials require new ways of thinking. We've talked a long time about precision oncology. We've made some gains, but I think there's a lot of room for improvement. So I'll start by just going through how we identified immune-mediated pathologic response features. And here is just a brief bit of background. So in non-small cell lung cancer, historically, there hasn't been a major role for chemotherapy before surgery, but in some cases it has been done. And the established method for assessing pathologic response after neoadjuvant chemotherapy was basically to take the entire tumor bed, which is the area originally occupied by the tumor, and divide it up into three components: viable tumor cells, necrosis, and stroma. And the critical aspect of this that I think is important to understand is that this idea of stroma does not distinguish between treatment effect and intratumoral stroma. So in effect, this is actually a tumor cellularity assessment where you get the percentage of the area of the tumor bed that is involved by tumor cells. So it's tumor cellularity plus or minus treatment effect. And the key variable that's been used to assess response is this residual viable tumor amount. And that's assessed across all the relevant slides. And here you can just see an image of a tumor. You've got tumor cells sort of along the periphery here. In the center, you have necrosis. It's difficult to sort of identify stroma, but they have this color-coded map here. And typically in a given slide, as well as across the case, these three components would add up to 100%. And you'd be assessing response based on this percentage of residual viable tumor. And I will just highlight that the IASLC published recommendations for assessing pathologic response after neoadjuvant therapy in 2020, and they sort of broadly applied this approach to all therapies, even though it was developed in chemotherapy. And so you'll see that we approach these specimens differently, and I hope with continued data emerging that we can modify those recommendations. So based on meta-analysis from patients treated with neoadjuvant chemotherapy, it was identified that patients who have less than or equal to 10% residual viable tumor have a significant survival benefit over those patients who have more than 10% residual tumor. So we're talking about 90% regression roughly versus those who have less than 90% regression. And this is the origin of this term major pathologic response. And, you know, this is a really valuable clinical endpoint. So, you know, in breast cancer, the focus is on complete pathologic response. Here they found that with 10% residual tumor, we still get a survival benefit. But it's a valuable clinical trial endpoint because it's rapidly available. So instead of waiting 5 or 7 years for overall survival data to mature from a clinical trial, you can actually assess response at the time of the patients have surgery. So pretty quickly after final accrual, you have pathologic response data, and this can be used to assess relative efficacy of different arms in your trial. And so there's a lot of interest in using pathologic response as a surrogate endpoint for survival in clinical trials. And what the FDA really wants to see, and probably Health Canada as well, is really robust meta-analyses that show this strong association. And so I think we have to be very careful in not only the trial design, but also in how we're assessing and reporting pathologic response to ensure that across multiple clinical trials, we're able to generate this level of robust data that's going to be required in order for this to be an accepted endpoint. So I'm going to talk about two trials today. Both are neoadjuvant anti-PD-1 in non-small cell lung cancer. The first is the phase 1/2. This was the trial that I was heavily involved in when I was at Hopkins during my postdoc, and I was the main pathologist on this trial under the mentorship of Janice Taub. And then the follow-up to that was the phase 3 clinical trial. That's Checkmate 816. And that trial was an international trial, but central pathology review was actually performed at Johns Hopkins using the approach that we had developed based on the phase 1/2. So I'll quickly just highlight some of the really exciting things about applying immune checkpoint blockade in the pre-surgical setting. So first of all, there's a significant mechanistic justification for using this treatment in resectable disease. And the idea is that with the tumor in place, you can actually activate an immune response. So it's kind of functioning as a vaccine in situ. And then once the tumor is, definitively resected with the idea of hopefully curing the patient, you have a circulating memory immune response that's been trained against tumor antigens. And so the idea is that that circulating memory immune response is then able to eliminate any nascent micrometastases or recurrence. And I think the data is still maturing, but we're starting to see evidence that that's going to bear out. The trial that I was involved in at Hopkins was the first solid tumor trial using anti-PD-1 before surgery. And so that created a lot of opportunity, but also some challenges in terms of assessing those post-treatment specimens. And then from the research perspective, it's an incredible opportunity to study mechanisms of resistance. And, given all our technologies and our multi-omics, having that large quantity of post-treatment tissue is just an incredible resource. And I'm not going to really go into that today, but that's also something I work on. So the original phase 1/2 was actually just a single agent nivolumab. This was, really a safety trial to see if we were going to delay surgery. And we had pre-treatment biopsy and CT scans. The patients got 2 doses of nivolumab and then a CT scan just prior to surgical resection. And there was also blood collection and a number of correlative studies done that I'm not going to detail today. I think I've presented those previously. So we're really going to focus on what's happening in the tumor at the level of the H&E. And here you can see an example of a pre-treatment CT scan and a post-treatment CT scan paired with a pre-treatment biopsy showing these large, ugly nuclei of tumor cells. And at the same magnification, we see a post-treatment field where we have no tumor cells, and instead they're replaced by fibrosis and inflammation. And initially, we assessed these specimens using the method outlined from neoadjuvant chemotherapy. And based on that, we found that actually a very large percentage of the patients had a major pathologic response. So 9 out of our 20 resected patients had at least 90% tumor regression, which is pretty remarkable. It's about, it's on the order of under 5% generally for neoadjuvant chemotherapy. So at this point, the features of pathologic response following immune checkpoint blockade had not been described. And so what I'm going to talk through is just the systematic way that we identified these features in order to quantify treatment effect in this setting. So the first thing we did was compare the post-treatment pre-surgical CT scan of the mass to the resected mass in the surgical pathology lab. So we measure, this is the resection specimen that's been sliced, and we measure the size of the mass. We measure the size of the mass on the CT scan. And not surprisingly, there's a very strong correlation between these two measurements. Now, regardless of the appearance of this mass, we found that microscopically there was a lot of heterogeneity in the composition. So at one extreme, this mass is composed entirely of tumor cells. At the other extreme, this mass is composed entirely of what I call a fibroinflammatory regression bed. So, lots of fibrosis, lots of lymphocytes, macrophages. You can see some multinucleated giant cells. So a very cellular sort of wound healing and immune activated kind of appearance. And then, lots of gradations in between. So interestingly, and maybe a little unexpectedly, we also noted that there was frequently an outside-in pattern of regression. So this is a low power image. So outside the green line, we have non-neoplastic lung. Inside the blue line, we have our residual viable tumor. And you can see in the high power view here, we have keratin pearls, which are characteristic of squamous cell carcinoma. And then we have these big, ugly, cleared out cells. And what we found is that around that viable tumor, between the viable tumor and the interface with the uninvolved lung, there was this area of incredibly dense cellular infiltrate. And when we look at higher power, we can actually see some of these keratin pearls in this area, but now they're surrounded by multinucleated giant cells and lymphocytes. So no tumor cells present, but we have these residual keratin nodules, really supporting the idea that this regression area is the area where the tumor used to be, and the immune system has sort of eaten away at this much of the tumor in this particular image. So we coined the term regression bed. So in the current ISLAC guidelines, they would call it everything in the green line the tumor bed, and then they would assess the cellularity of the residual viable tumor. And the approach we use, which we call immune-related pathologic response criteria, or IRPRC, we're defining this area of treatment effect as the regression bed. So when we look in that regression bed, we see some histologic features that are pretty striking. We see cholesterol clefts surrounded by these multinucleated giant cells. So these are kind of artifacts of lipid accumulation. We see this fibrosis, but it's very cellular, sort of suggestive of a sort of earlier stage of fibrosis, which I would contrast with this very collagen-dense, more mature fibrosis. We also see numerous lymphoid aggregates and tertiary lymphoid structures. There's been a lot of follow-up work focusing on this aspect of treatment response. There's a very dense lymphoplasmacytic infiltrate. And I'll say these were the first specimens that we saw post immune checkpoint blockade. And it was the density of the lymphocytes was striking. And in other contexts, you might wonder if there's some kind of lymphoma happening. This is not a normal feature of tumors. Foamy macrophages, so these macrophages filled with lipid, and then neovascularization. And I will say that one of the things that really helped us is the fact that my mentor, Janice Taub, is a dermatopathologist. And in melanoma, you can see spontaneous regression, and you see many of these features in the place where the melanoma used to be. So, probably spontaneous immune-mediated regression, because we know melanoma is a very antigenic tumor type. So to systematically approach defining response features, we compared the two extremes of the cohort. So if we're talking about a spectrum of residual viable tumor from no tumor and a complete responder to 100% residual tumor, we took patients at either end, so complete pathologic response or major pathologic response. And those we had 9 patients, and then the non-responders. So at least 90% residual tumor. And of those, we had 4 patients. And we scored a number of histologic features to determine which were most strongly associated specifically with response. And so you can see those boxed in orange or in red here, many of which I just showed you. And what we conceptualized here is that these features actually fall into sort of 3 broad categories. So evidence of immune activation, these patients got single agent anti-PD-1. So if we don't see evidence of immune activation, it's almost certain that the therapy did not work. So this was, in that setting, it's kind of mandatory that we see immune activation in order to call something treatment response. We also saw evidence of massive tumor cell death, which leads to a lot of membrane lipids in the tumor microenvironment. So the membrane lipids are what are giving us these cholesterol clefts and foamy macrophages. And then finally, evidence of tissue repair. So this proliferative fibrosis and neovascularization. And again, this is a cell-mediated physiologic mechanism of cell death. And so it's intuitively, it makes sense that the body would have these repair mechanisms to sort of clean up after the immune system destroys the tumor. So based on these features, we defined immune-related pathologic response criteria, with the idea being that we can actually recognize specifically treatment response and measure it. And one of the features that distinguishes this from the existing recommendations from ISLAC is that if there is stroma here within the viable tumor, we count that as tumor. So if we see stroma that we interpret as tumor-associated stroma unrelated to response, it just gets lumped in with the tumor. And so everything that we're calling regression then is essentially treatment effect. And so we're defining the regression bed, we're distinguishing treatment effect from other forms of inflammation and fibrosis. We use an area-based calculation to account for different amounts of tumor on different slides. And because we see this outside-in pattern of tumor regression, we think it's very important to submit a complete cross-section of the tumor specifically for pathologic response assessment. And that's a recommendation that's also included in the ISLAC guidelines. So importantly, I will note that in an untreated tumor, you could potentially see inflammation, you could potentially see some fibrosis, there could be an obstructive pneumonia that results in foamy macrophages and cholesterol clefts. So none of these individual features are specific for treatment response. What it is specific for treatment response, or relatively specific, is the constellation of features and their geographic association with the tumor. And so, this is really about pattern recognition, and that's exactly what pathologists do all the time. It's not that one of these features is enough to define response. So after defining this kind of new method of assessing treatment effect, we asked 4 pathologists at Johns Hopkins who were not involved in the study up to this point to score our specimens. So we had 1 for training, and then we had 19 specimens. And first, we just asked them to score response based on the existing recommendations that were developed in chemotherapy. And then we talked them through our data, showed them what response looks like and how we measure it with immune-related pathologic response criteria, and had them rescore the specimens. And so the chemotherapy criteria are shown in blue, immune-related criteria are shown in black. And what you can see is that the range of scores is narrower for immune-related pathologic response criteria. Now, obviously, at the extreme of having less than 10% tumor, there's not a ton of variation. What's a little more surprising is at the other extreme, where there's a lot of residual tumor, there was actually a shocking amount of variation in the cellularity of the tumors. And so when you're looking at tumor cellularity to varying degrees, you're getting these very wide ranges of residual tumor, whereas when we distinguish response from intratumoral stroma, we're getting more consistent reads. This example, case 11, was one where the tumor had an adjacent obstructive pneumonia. And so a lot of, upon the original scoring, the obstructive pneumonia was included in the calculation. And so that resulted in a very low percentage of residual tumor, whereas defining both the geographic and the geographic distribution and the constellation of features of response, it was identified that the obstructive pneumonia was sort of separate from the residual tumor, and actually it contained neutrophils, which are not an indicator of treatment response. And so we got a dramatically different score. So a lot of the scores are the same, but in some cases it does make a big difference. And here is an example of why I think it is important that pathologists distinguish treatment effect from stroma in general. So on the left, you have a case where we have islands of tumor epithelium pointed out by the arrows. And then in this background, we have a very cellular infiltrate of lymphocytes and macrophages. We have some cellular fibrosis. This has the constellation of features. You can see actually some of these lighter areas with these foamy macrophages, really suggesting that we have some cell death in here. So, this is a situation where these epithelial islands are in a background of tumor regression. And so there I would say, the residual viable tumor is on the order of, maybe 20% in this image. On the right, we have a highly infiltrative tumor. And again, the tumor epithelium is pointed out with the arrows. But the background here is a paucicellular, collagen-rich tumor stroma. And in this case, I would score this as 100% residual tumor. Whereas if we were assessing cellularity, we would again get 20% or 10%. So this is, I think, the pitfall of conflating tumor cellularity with treatment effect. So I'm going to move now to talk about some of the more recent data in Checkmate 816. The study was published in the New England Journal. We've also got some more updated data that's been presented recently at ASCO and ESMO. So again, we had now we're moving to nivolumab plus chemotherapy. So there were several smaller trials showing that the rate of complete response and major pathologic response was even higher if you use the combination of anti-PD-1 plus chemotherapy. And you can see, the early readout was event-free survival significantly improved with the combination. Overall survival was also significantly improved, and the rate of pathologic complete response was about 10-fold higher in the combination therapy versus chemotherapy alone. Regardless of the treatment arm, pathologic response correlates with the survival outcome. So you can see here that even patients who got neoadjuvant chemotherapy, if they had a complete pathologic response, their event-free survival was very good, as well as for the patients who had a complete response in the combination therapy. And these patients who had this pathologic response didn't even get to their median survival. Again, here we have another estimate of the percentage of complete pathologic response and major pathologic response, and this is using a slightly different denominator based on the number of patients that were actually resected. And you can see that the rates are significantly higher in the combination therapy arm. So obviously very exciting data and warranting the clinical approvals that followed. This is some more updated data. So here we have event-free survival stratified by percentage of residual viable tumor. And this is, specifically in the patients who received the combination therapy, where we actually have more robust numbers at different amounts of residual tumor. And so here they've assessed 0 to 5%, 5 to 30, 30 to 80, and then greater than 80%. And you can see that there's a bit of a kind of continuous association between the amount of residual tumor and the survival outcome. And I think what's important to note here is that we continue to use major pathologic response as an endpoint. However, it is not clear how much of a pathologic response is needed for a survival benefit in the setting of immune checkpoint blockade. So, it may be that a response rate of 30% residual tumor is a meaningful cut point. And I think this is a space where standardizing our data collection and reporting is going to be really important to have the robust statistical power to actually determine what the most meaningful cut points are for the design of our trials and for making treatment decisions about adjuvant therapy. So my colleague Julie Stein and Janice Taub at Hopkins submitted some recent analyses of lymph node involvement in these specimens. And currently, the recommendations are that a patient who has a complete pathologic response in the lung but has positive lymph nodes is called a major pathologic responder. And I think this lymph node space is one where we really need data to sort of define how we interpret response in the lymph nodes. So this breaks the specimens down into those who had lymph node involvement versus those that don't. And when we say lymph node involvement, we mean actual tumor in the post-treatment lymph node or treatment effect. So these are patients who had totally normal lymph nodes with no evidence of having ever been involved with tumor. And these are patients who had evidence of lymph node involvement, be it treatment effect or residual tumor. And so not surprisingly, the patients without any lymph node involvement are ultimately doing better than the patients who had evidence of lymph node involvement. But interestingly, we can look now at the treatment response in the primary tumor and the treatment response in the lymph node, which was also scored. So in this light green, we have patients who had a non-response in both compartments, and those patients, not surprisingly, have the worst survival. In the darker green, we have patients who had no residual tumor in the primary or in the lymph nodes, but they had the evidence of treatment effect, and those patients have the best survival. And then in between, obviously, we have patients who either have tumor in just the lymph node or tumor in just the primary tumor in the lung. And those patients have intermediate survival. And obviously, we're getting down to very low patient numbers here, so it's hard to make any meaningful distinctions between these two groups with this data set. So, I think intuitively, it's not surprising that what's going on in the lymph nodes is going to be very important in terms of predicting patient outcomes. So, as I mentioned before, the central pathology review was performed at Hopkins using immune-related pathologic response criteria. And so we actually scored the regression bed as well as the amount of necrosis and residual tumor, and had the data for all three. So this is showing the distribution here. So the residual tumors in the dark bar, and at this cut point, we have 0% residual tumor. So these are complete pathologic responders. Necrosis is shown in the lighter bars, and then regression, so our treatment effect measurement, is shown in the intermediate color. And what you can see is that predominantly in both the combination therapy and the chemotherapy, patients who responded are having most often this regression bed, so this fibroinflammatory treatment effect. You do see some necrosis. I would hypothesize that necrosis is probably most likely related to the necrosis that was originally associated with the tumor rather than treatment effect. And this is focusing now just on the combination therapy. And again, not surprisingly, we see a strong association between the percentage of residual tumor and event-free survival. And so again, this is showing the sort of continuous relationship between the amount of residual tumor and patient outcomes, and we have an AUC of 0.74. And then importantly, we also have data looking at the percentage of regression. And here we have, again, a very strong association with event-free survival. And so I think this is really the point of data that confirms that when we think we're measuring treatment effect, we are, because we can tell that the patients who have more regression have better survival outcomes. So I think this is a really important piece of data supporting a change in approach from tumor cellularity to assessing regression specifically. So, what does pseudo-progression look like from a pathologic point of view? Does IRPRC help to identify that in the neoadjuvant setting when assessing for pathologic response? It's a great question. I don't know the answer. In our original 20 patients in the phase 1 trial, we didn't have any pseudoprogression. On radiology, the vast majority of the patients showed stable disease, using 30% as the cut point for for response. I don't know if there was pseudoprogression in 816, but we are doing a pathology focused study that's ongoing, and I will add that question to the list. So every time I give this talk, people come up with great questions, and then I send to Janice, add it to our list to look at for this pathology focused paper on 816. In terms of how IRPRC, so pseudoprogression, meaning that there is an influx of lymphocytes and other cells that make the tumor look larger, but actually it's not the tumor growing, that would be captured in IRPRC. We would basically define those areas as regression, and we would report that as response. That would be in contrast, I guess, to hyperprogression, which I also haven't seen. And in that case, I believe that the IRPRC approach would work effectively in both cases, but I don't have the data. Okay, so I'm gonna shift now to a pan-tumor approach to pathologic response assessment. And this is, I think a really important concept. So not surprisingly, the global landscape of neoadjuvant and adjuvant trials that include immune checkpoint blockade is absolutely exploding. So on the left, we have the data up until 2020 showing the increased rate of these trials in all three phases. And of course, as the phase 2 data emerges, we're going to get more phase 3 trials. And on the right, they're broken down by those with a neoadjuvant component versus adjuvant only. And you can see that the vast majority have a neoadjuvant component. I think that's good. I think these therapies are well suited for the neoadjuvant setting. There's some data in melanoma. This was a meta-analysis across a number of neoadjuvant treatment approaches, showing that pathologic response is associated with survival. And here they've got cut points, they're calling 10% a near PCR. They've got a 50% cut point that they're calling a partial response, and they're defining non-response as over 50%. And here, these bear out as statistically separate. I think, what's important is that many of these cut points are relatively arbitrary, and we really need data to drive the selection of the most meaningful cut points. I think a potential challenge for the field is going to be the proliferation of different scoring systems. And of course, I've contributed to this problem with IRPRC, but, we have now 2 different competing systems in lung cancer. Every new tumor type that has a neoadjuvant study is, sort of left to its own devices in terms of defining how to assess response and defining the most meaningful cut points of response. And so you can imagine that this is going to create a lot of inconsistencies in the data, which is going to make it very challenging, I think, to do robust meta-analyses, even potentially within a single tumor type. And what's really exciting is that the features of pathologic response following immune checkpoint blockade are very similar across tumor types. So this was work that's was really led by Julie Stein. She's currently a pathology resident at Hopkins. And she's looked at over 500 on-treatment specimens across 10 different tumor types. And so here you're seeing head and neck, Merkel, vulvar, cervical, renal cell carcinoma. And you can see that they all are incredibly similar, very cellular, lots of lymphocytes, tertiary lymphoid structures, lymphoid aggregates. You can see, neovascularization, plasma cells, cholesterol collapse, foamy macrophages. So a very consistent set of features that are indicative of response across tumor types. And so we really have the opportunity, I think, to standardize our approach to pathologic response assessment here. Some other exciting work that Julie led was focused on treatment biopsies in melanoma. So she had a discovery cohort of archival specimens, and then a validation cohort from a BMS trial where patients were biopsied 4 weeks post-treatment. And what she was able to do was identify the features of pathologic response in on-treatment biopsies and develop a scoring system. And so the scoring system combines the number of features of pathologic response, co-localizing, as well as the amount of residual tumor. And she was able to show that in on-treatment biopsies, if you have at least 3 features of pathologic response, as well as less than 10% residual tumor, these patients have significant overall survival benefit over 5 years. And the reason that identifying the features of pathologic response specifically is important in this setting is because you can imagine a scenario where a post-treatment biopsy is performed and they just miss the tumor. And so, of course, you wouldn't want to call that a complete response, even though there's no tumor in the specimen. You want to see that evidence of immune-mediated tumor regression. So this is where I think we are hoping to radically sort of change the way that we are operating, traditionally very siloed by tumor type, but we're optimistic that a pan-tumor approach for pathologic response assessment is possible. It's going to save a lot of energy in terms of people developing their own approaches, and it's going to generate reproducible data. And I think whether or not we end up with the same cut points in terms of thresholds of pathologic response that are associated with survival is an open question, and that can certainly be different for different tumor types. But if we're collecting the data in a uniform way, we can actually ask those questions. So SITC and some pharma partners are sponsoring a validation study. So we'll be developing resources as well as generating reproducibility data using a number of pathologists assessing specimens across tumor types to demonstrate that this is a feasible approach to assessing pathologic response. And I think this is not so radical in the sense that we've already have a precedent for pan-tumor approaches when we're talking about immune checkpoint blockade. So obviously PD-L1, although it doesn't perform the same in every tumor type, is a biomarker that is useful across multiple tumor types. We also have things like microsatellite instability, where we actually have a molecular indication for treatment that applies across tumor types. So I think, in this era of immunotherapy, this is going to be increasingly possible, and I think will contribute substantially to our ability to design trials for precision care. And then also, we have the exciting developments of ctDNA in terms of being able to potentially de-escalate and monitor response. And you can imagine a scenario where if we're seeing very high rates of complete pathologic response and we're seeing very strong correlations between complete pathologic response and survival, we may not need to do these surgical resections in a subset of patients. We may be able to follow them with ctDNA. And so another idea that feels radical, but I think is going to end up having the data, hopefully, to support some new approaches. So, this is where I think breaking down some of our silos and working across tumor types and across trials, we could potentially rapidly accelerate the rate of getting new therapies into the clinic. And so you can imagine if we have neoadjuvant therapies and we have pathologic response as a validated surrogate endpoint for survival, as soon as we're able to accrue these studies, we can report the data and apply for regulatory approval. We're also able to report this data and more quickly accumulate data for meta-analyses. And so this could really change the pace of getting new treatments into the clinic. And, obviously there are a lot of different immune-related molecules that are being tested. And so there's a huge landscape for rapidly introducing these therapies into the clinic. And then I just wanted to plug that the Canadian Cancer Trials Group, which is obviously based here, is really trying to leverage this opportunity, and this is the effort that I'm leading. And I think, what we're hoping to do is across Canada really streamline the process of neoadjuvant clinical trials. So from trial development to trial conduct and biomarkers and correlatives, we're trying to position ourselves as really a place where we can get these trials done quickly, at a high level with robust correlatives and hopefully integrate all of that data. So I think there's a lot of really exciting work to come, and I'm sure I'll come back and tell you about it at some point. So again, my take-home message is, I think it's extremely important to continue to remember that immune checkpoint blockade is not a new version of chemotherapy. There's a different mechanism of action, and that has implications. I think preoperatively, it's going to be a highly effective therapy. when we're thinking about long-term follow-up, we've got the immune system activating even after we stop the therapy. So there's a lot of differences. There's really an imperative for us to take action towards standardization. We have an opportunity right now to avoid the mess that was created by the PD-L1 testing with all the different assays and all the different cut points. Hopefully, as a field in pathology, we can sort of learn from that. And then I think we can start to at least think about some really radical ideas like pan-tumor clinical trials, de-escalation of resectable disease. If we have evidence that the patient likely has a pathologic complete response, we can do a non-treatment biopsy, we can follow ctDNA. So I think there's some really cool opportunities for us if we're willing to take those risks. So that's all I have. I'm happy to take questions.
Okay, thanks very much, Tricia. So if you have a question, just chime in. Okay, Andrew, go ahead. Andrew.
Sure. Yeah, that was fabulous. Thank you for that talk. I guess a couple of questions. You mentioned the immune-related response criteria, and the 816 was immune therapy and chemotherapy, and a lot of the various sort of combinations and clinical trials might be immune therapy and targeted therapy, immune therapy, chemotherapy, targeted therapy alone, and driver mutation, and so on. I guess my question is, if you're standardizing approach, is it possible, like given that people are trained as thoracic pathologists sometimes and not as immune pathologists, is there going to be a push back against having sort of different classification schemes for each modality of therapy? And sort of the similar question to that in 816, was there any way that they could get a sense from the chemo responses and the chemo IO responses how much the immune therapy was adding? In other words, did it look different if it was a chemotherapy only partial response versus a chemotherapy immunotherapy one?
Two really great questions. So the first question about different methods of scoring response for different therapies is a very important one. And I think that is what ISLAC was trying to get ahead of with publishing their recommendations and sort of applying their recommendations to immunotherapy without having really the data to support it. We believe that our approach will be applicable across treatment settings. I think you can see here with the chemotherapy, these chemotherapy specimens, as well as these combination therapy specimens, were scored with IRPRC. We probably need to do specific analyses to show, for example, like we have here, that regression in our combination therapy setting correlates with EFS. I think that same curve with chemotherapy, if we have adequate responders to have a meaningful curve, would support the use of this approach in chemo alone. Although I think we're maybe, unless we have a biomarker that tells us that a patient's going to do well with chemo alone, there's probably not many patients that are going to get chemo alone these days. But so I do think it is extremely important that we as a field of pathologists put our egos aside, and I'm fine with whatever terminology we can agree on, but I think we do need to take that leadership role of simplifying this and having some clear messaging for the community. And I think as the data emerges, that will be easier and easier. I think right now we're just in a place where we don't have a lot of data, but I think asking those questions in our data sets is incredibly important. Your second question was, remind me, it was a good one. I know.
Sure. So, okay. The second question was in terms of differentiating for patients who are on multimodality therapies, chemotherapy and immunotherapy, for those patients, let's say in the middle, that have residual tumor, is the
Oh, does it look
response look different for if it's a chemo-only effect versus the immune system activated as well?
Yeah, right. So we are hoping, we have not been unblinded. So these were scored blinded to treatment arm. So in that sense, when we call something, when regression was scored in this trial, we didn't know what the treatment was. So that would suggest that that it looks similar in terms of what we scored as regression. That being said, part of that pathology specific study is to be unblinded and specifically compare the chemo alone to the combination to see to answer that question. So we don't have the data yet, but yeah, it's a good question.
Thank you. And I know Jonah's got a question. One clinical question: if a patient has their tumor cut through, and it's the residual or the regression that's cut through, is that reported as a negative margin? But it's cut through the area of regression. And we can be confident there's no additional disease there.
That's a great question. I'm sorry, I'm making notes. Margins with regression, but that would be called typically, unless we have tumor cells on ink, we call the margin negative. So yeah.
Thank you.
Hi, Tricia. Thank you.
Hi.
Yeah, Jonathan here from Belleville. Fantastic talk, Tricia. I think you're in a space where, bench to bedside probably doesn't mean anything more than what you're doing, because we're basically trying to correlate response and dicing people's surgical specimens to figure out what exactly is going on pathologically. So I thoroughly enjoyed your talk. It's a very complex space, and I think you're doing great work. My question is a bit of a takeoff from your work to imaging. We struggle. I mean, in this case, you've got neoadjuvant patients where you have surgical specimens to deal with afterwards, which is nice academically. But in the metastatic setting, we often struggle to assess response. And we still deal with just conventional CT imaging to try and sort of assess, okay, am I seeing response or is this progression? And in critically ill patients, sometimes it's a very difficult judgment to call. And so my question is, do we have, in all the studies you've done, perhaps others as well, is there sort of predictable markers that could be used as isotopes in scans like PET imaging and stuff, where we can actually sort of image patients to assess response using what we've learned pathologically?
It's a very good question. I can say that we are doing a deep profiling of the post-treatment tumors using multiplex immunofluorescence, and I don't have that data yet, but we have a number of panels, and the plan is to really characterize we've characterized the treatment effect at the level of H&E, and we can sort of grossly distinguish cell types. But obviously with something like multiplex immunofluorescence, we can get much more granular about phenotypes of those cells and subsets and particular molecules being expressed. So it's possible that we will identify either a marker or a pattern that may be useful in radiology. I don't know how far away that is, but I think I do think that it's possible. I think it would be more likely to be some kind of pattern. But yeah, I do think it's possible.
Just as a footnote that I can tell you, like in tumor board rounds and stuff, our radiologists often do struggle, and often reports we get a simple report saying progression, right? And I think it's a sort of big blocks and evolving field, and even DI education trying to sort of come to grips with what we are seeing in cancer and these kinds of treatment responses. even with
Yeah.
conventional imaging.
Yeah, I mean, I think there are a couple other things. So obviously I know people don't want to do a biopsy in a sick patient, but on treatment biopsies, I think are a potential avenue for getting some information about what's going on. The other thing that is potential is that it may be that there are features in the CT scans that we just aren't picking up. And so maybe an AI approach, because we have the scan and we have the resected tumor, we can sort of do that comparison of, okay, these are complete responders, these are what their scans look like, and so it may be even that there are features in the CT scan that a sophisticated algorithm may be able to pick out. So, obviously that's more Amber Simpson's field than mine, but I think these trials are going to create opportunities to do those kind of studies.
Okay, thanks, Tricia. I think it's getting close to the hour, but if there's one or two quick questions left, we can. I was going to ask, just following up on Jana's talk or Jana's question, the idea of being able to monitor patients afterwards in ideally some non-invasive way. You mentioned circulating tumor DNA as one approach. I'm wondering if people are also thinking about trying to assess the residual immune memory, if you like, that we hope is going to happen with these immune checkpoint blockades. Are there approaches being developed to actually assess that, the presence of memory T, B cells, and what their status is in terms of activity?
Yeah, there are. And Courtney, I see your question, so I'll answer you. Yes. So here, this is the best slide I have to talk about it, but Kelly Smith is really a leader in this space. She's at Hopkins and she's an immunologist. And what she does is whole exome sequencing on the pretreatment tumor, identifies the neoantigens, and then generates peptides corresponding to those antigens. And then she's able to stimulate in vitro the T cells from the patient's blood at various time points. And the readout that she uses is TCR sequencing. So, each well of the plate has a different antigen. If the T cell reacts to the antigen, it expands. She can identify its TCR sequence, and then she can go back in the blood and look for that specific TCR sequence across different time points. And so that's I know it was called her manifest assay, MANA, like mutation associated neoantigen fest. I don't know if she has a new name for it. She's shown in our original phase 1 data, the presence of tumor antigen specific T cells post-surgery. And I always forget the time, but I want to say like 6 months or a year, but a substantial amount of time after surgery, those cells were still circulating. So she definitely has the technique to do it. I don't know. I guess I don't know if that's a clinic, but it's more of a research question than a clinical question. I guess. But yeah,
like that's really exciting. Yeah.
Yeah, it's a very cool approach. And so, Courtney, I see that you've asked about implementation in standard of care. So, I don't know. I mean, so here we've met. We only have 4 pathologists that are doing lung. I'm going to tell them what I know. We're going to provide training materials for the gross room to submit a complete cross section. I think that we'll have to decide. I think we'll probably report the data both ways in terms of cellularity and IRPRC, because I think it with the current ISLAC guidelines, it's kind of tricky. I imagine it will vary by institution. I think this is a thing we could review at Tumor Board if there was a question about the pathologic response assessment, but in the same way that we review diagnoses and things, but I don't know. I don't know about a QA approach. I think it's a good thought, and I can bring that up to Janice in the context of the SITC study that we're doing, if that would be a part of the recommendations. Fortunately, I think, so if 10% residual tumor is the clinically relevant cut point, that's a pretty striking situation. So, you know, even when regardless of whether you use the cellularity or IRPRC, 90% regression is pretty striking. So I think that we'll be okay. It may get more challenging if we're looking at a cut point like 30%, you know, I mean, there are always challenging cases. So, you know, I think we intuitively show each other challenging cases, and this would probably not be different, just to get a second opinion, but I don't know, it's a good question.
Okay, I see, I think some people are having to head off to their regular day jobs. But those of you that are left, please join me in thanking Tricia for a wonderful talk. And I think we're going to have to get you back, if not this venue, some other on a fairly regular basis to see how this research is going. And wonderful to hear it from you. I've heard from some of your students recently, but it's great to hear it from you now. So thanks very much, Tricia.
Thank you. Thanks for the invitation and the good questions.
Yeah. Cheers, everyone. Have a good day.
Bye.